Coming.
Okay. I have to work around my patients. Hi, everyone. I'm Lauren Burke from UNC. It's so nice to be here, and thank you so much for the invitation to speak today. I'm going to be speaking about incorporating international graduates. I have no disclosures. I do want to note, though, that I'm not an expert in immigration policies. I know a little bit about visas. I know a little bit about immigration, but probably just enough to make me dangerous. These laws change all the time, and they're different per state, so it's always best to seek advice. So that is my true disclosure. We're going to go a little bit through background, recent trends, and then discuss the alternate pathway through ABR. Everyone has seen this. We are in a shortage, right? The shortage is thought to be up to 42,000 radiologists in 2033. Why are we here? Well, the population's growing faster than we're training every year. The residency positions have remained stagnant for about 30 years. More imaging studies are ordered per provider. These imaging studies are increased complexity, and cancer is fueling greater imaging needs. Put another way, this blue bar is our imaging volume, and then this is our workforce, the orange is our workforce growth. Unfortunately, oh goodness, when I look at this, I see us right here in 2025, and then I see this growing in 2033. Everyone has seen this chart too, more than 1,000 radiology jobs opening annually. So going into current trends, about 25% of all physicians in the States are international foreign graduates. About 11% of all radiologists are IMGs, and that's from 2021. You can see in the yellow in this graph, the IMGs within trainee programs, and that's actually been increasing pretty significantly. They were about 2% in 2006 and up to about 15% in 2020. So one strategy is to encourage growth through the ABR alternate pathway, and that's for those international medical graduates who are not planning to enter a standard radiology residency, but coming into the workforce. So let's talk briefly about that pathway. There are a few prerequisites. You do have to pass all 3 USMLEs. You have to be certified by the ECFMG, and you will have to have finished your radiology training abroad so you can practice independently within your home country. It's 4 years. They don't have to be contiguous within a single ACGME accredited program. After about 3 years, you can sit for your core exam, and then 4 years, you can sit for your certifying exam. And if you follow this, there used to be 4 months of nuclear medicine training. That was before 2024, and that no longer is the case unless you do practice nuclear medicine, of course. Okay, so we can't talk about the ABR pathway unless we talk about visas. I'm going to give you my most simplistic view of this possible. There are 2 that we typically talk about: J1 visas, H1B visas. There is an O1-2, the exemplary, but we're going to talk mainly about the J1 and H1B. And I'm going to tell you, as simplistic as I think about it, the J1 to me is a training visa. These are typically easier to obtain. They're cheaper to obtain. They're shorter in processing time. But this radiologist cannot independently sign. They cannot moonlight, and there is a subject to a 2-year home country presence unless you get a J1 waiver. And so J1 waivers, excuse me, are typically in underserved areas. Unfortunately, in my institution, we are not able to give J1 waivers. So this is something that needs to be kind of taken into account. Again, that radiologist cannot final sign any reports. I think of an H-1B visa more as a working visa. These take longer to process. They're a little bit more costly, but they allow the individual to stay within the US and apply for permanent residency. And then these individuals can final sign and really function as a faculty member while they're with you. You can't talk about visas without talking about state licensure as well. You always have to know about your state and the rules, how many years of ACGME accredited fellowship to gain a full medical license. So you can find your state here, whether it's 2 or 3 years. In the meantime, IMG pathway radiologists can have a temporary license within your state. So it is still possible, but you just have to know the rules of each state. Okay, let's talk a little bit about benefits. And there's so many benefits here. You really, truly get high-quality radiologists coming into your department. I cannot stress this enough. You get diversity of thought processes and operations, which leads to better patient care, decreased health disparities. You get dedicated, loyal radiologists within your department. And you can hopefully retain these folks after the 4 years. I think anyone would be hard-pressed to say that after 4 years at a single institution, they don't know the ins and outs, the referring physicians, and have really become even a better radiologist. I know I would be too. Oh, thank you. These folks also have a greater research experience in terms of publications, abstracts, and compared to the US counterparts. You have to talk about unseen stressors as well, though, right? Visas always have delays. There's travel restrictions associated with it. There's culture and language barriers. Dictating in another language can be really difficult. Really give them the time to be able to do that. They have higher USMLE fees. And they also, I hate that I have to put this on here, but can be subject to microaggression or discrimination. So just like Sherry said, we need inclusivity. But as a specialty, we really have tremendously benefited from them being in our workforce. Be kind and be welcoming. This is a recent radiology article from 2025 that really kind of highlights a lot of this stuff that we just talked about. So if you need a reference, I would go into and read this one. So thank you.
Pulmonary hypertension. The dilation of the pulmonary artery causes compression of the left main coronary artery by its downward displacement and reduction of this takeoff angle. In this 57-year-old woman with chest pain and troponin rise, this CT scan revealed the longer left main coronary artery compression between the pulmonary artery and the aorta. The evaluation of the takeoff angle is very important to us. We can do it in coronal view. This takeoff angle is generated by two bisectors. One is represented by a line drawn in the middle wall of the left main coronary artery, and another line is orthogonal to the aortic valve plane. A takeoff angle lower than 60 degrees represents a high risk feature. Based on the CCTA results, in this reference, patients can be categorized in these four groups according to the relationship between the pulmonary artery and the left main coronary artery. In figure A, you can see this normal distance, more than 1 millimeter, but look at figure D. This compression over 50% of the left main coronary artery caused by a dilated pulmonary artery. But in which cases we can predict this compression of the left main coronary artery?
By the way, with the approval of this drug, the FDA actually overtly recommend that we test for APOE4 allele status.
And the pulmonary artery relation more than 1.2 to 2 is reasonably predictive of stenosis of the left main coronary artery over 50%. And the risk compression increases when the pulmonary artery is over 40 millimeters. Look at this another extrinsic compression. This is a 32-year-old patient with a round mediastinal mass that compresses about 50% of the left main coronary artery at its origin. So we categorize him in CADRATS 3 and, of course, modifier E. And finally, here we have an example of coronary narrowing in an 8-year-old child with Kawasaki disease. Here we can see the proximal dilation of the right coronary artery and this focal aneurysm. To your right, we can see this thrombosed aneurysm and this total occlusion in LAD. Here we can see a collateral vessel that supplies this blood flow to the LAD, and also, in left main coronary artery, we have this focal aneurysm pre-bifurcation. So this patient report conclusion should include modifier E, even though he is only a child without risk factors. The message that I want you to take home is that modifier E refers to any non-atherosclerotic cause of compromised flow in the coronary arteries. I have shown you some cases of coronary artery that have no significant narrowing, but with disturbances in their flow, and this must be considered and include as an important finding with modifier E. We know that these exceptions are far less frequent than atherosclerotic disease as a cause of coronary narrowing, but they remain an important differential diagnosis to be considered and recognized. And I want to take this moment to show you this image of the heart through the eyes of Leonardo da Vinci and the way we are able to see the heart nowadays. So I think we are very lucky to be right here and right now. Thank you very much.
The accuracy is much higher than it used to be. So there is a role for these tools in evaluating these particular patients. They essentially look at your brain volumetrics against an age and sex match population. It can give you insights as to a differential diagnosis by the pattern of brain involvement. But perhaps most importantly, you can use this information to inform prognosis. If you start therapy and there are no volume changes, that could very well point to a much better outcome. These are expensive drugs. You may at some point decide, well, this patient's brain loss is so formidable that I don't think that removing the amyloid at this point might help. It's going to be an interesting thing, but we do know that there are certain characteristic patterns of volume loss that occur in the brain in dementia. And if you're looking at an Alzheimer's case, as you've already seen, you're going to see temporal lobe volume loss, hippocampal volume loss, maybe some parietal volume loss. The frontal lobe is generally spared, and there's not a lot of white matter lesions. Frontotemporal dementia tends to affect the frontal lobe and temporal lobe, but will eventually get to the hippocampus. Again, sparing in this case the parietal lobe. Vascular dementia generally is characterized by a lot of white matter lesions with some atrophy that can occur in typical locations. And the Lewy body dementia doesn't have a very characteristic pattern. I like this particular indicator because I think from the back of the room, it points to the disease that you need to look for, right? And I think, this could be very useful for communicating with family members as well. You want your numbers to be in the middle of this spot at the 99th percentile-ish, okay? But when you have a frontotemporal dementia, you'll see that you're down to the lowest percentile in terms of frontal lobe volume, the lowest percentile in terms of temporal lobe volume, sparing the parietal and hippocampal areas in this case, whereas in an Alzheimer's case, you're pointing at the classic structures that are involved in Alzheimer's disease. And this kind of gives you a whole holistic way of looking at things. There's a lot of numbers that come out of these reports. It kind of distills it down and helps you ignore some statistical noise and focus on the actual patterns of involvement. This is a case loaned to me by Dr. Bash. If you haven't figured this out yet, Dr. Bash is the doctor who leads used to be our nationwide effort at imaging these particular patients. And she loaned me this case where she saw this patient with a compelling dementia picture in 2009, some volume loss here. You can see on the neurodegeneration FDG PET scan, there was clearly hypometabolism in the temporal lobes. It was a PET CT she fused to the MR. Several years later, you can see the atrophy has certainly progressed. If you look closely, you can see the classic pattern of involvement as well as the fluoridally positive amyloid PET scan. Now, one of the things that we can't see with our eyes is progression over time. It's just too subtle. And the fact that this patient had in one visit frontal lobe volumes that were respectable, but then became pretty much an outlier would be very difficult to appreciate between exams. So these tools, these AI-driven tools can be very, very helpful in giving us that longitudinal information. These can be plotted in the spider graph or a nomogram. It can be plotted against, the standard deviations from of an age-matched normal population. These are the white matter hyperintensities or flare hyperintensities in a different disease case. But the point is you can use these tools to see things we couldn't appreciate. All right. So now that we're giving these drugs to patients, the role of MRI has changed. We now have the obligation to look for people who have a risk of bleeding, because when you loosen amyloid, it becomes an inflammatory focus. The inflammation is largely vessel-based, and inflamed vessels like to leak edema, like to leak blood. So you want to look for circumstances where you might be at higher risk. And I keep alluding to these complications that occur with these drugs, and they're referred to as amyloid-related imaging abnormalities, which doesn't tell you much. What they really are amyloid inflammation related changes in the brain. And since a lot of the amyloid is in the vessel wall, that's where all the green is here in the brain parenchyma and the vessel wall, the earliest changes tend to affect the vessel wall, and we see complications associated with leaky vessels. You're going to get, they will either leak edema in the substance of the brain or on the substance of the brain. That would be on the substance of the brain or in the substance of the brain, or they'll cause hemorrhages, either microhemorrhages or superficial siderosis. As a matter of fact, that same electron micrograph shows that in these amyloid-involved blood vessels, you'll even have aneurysm formation as well. So it's not a minor thing to inflame those blood vessels. So you'll see edema in the brain or sulcal effusions. You'll see microhemorrhages or even siderosis. So let's look at some examples. Here's a patient who has sulcal effusions, ARIA-E. You see this is a FLAIR scan. The cell size should be dark, but you see these are not. Okay, and that represents a sulcal effusion. Here's a patient who had nothing on the pre-treatment exam. After treatment, there is now edema in the brain on both hemispheres. This led to a temporary cessation of therapy and a spontaneous resolution over a couple of months. Here's a patient pre-treatment, no evidence of hypointensities. Post-treatment, you've got maybe 15 tiny little microhemorrhages. And microhemorrhages in the brain on an MR look very much like microhemorrhages in the brain on a cadaver. Little tiny shrunken down deposits of hemosiderin. That's one way these manifest. That's in the brain, but it can also manifest as on the brain, superficial siderosis, as you see here. Actually, you might even have a couple of parenchymal hemorrhages as well. So here's just a quick case, from the literature. Patient baseline screening, no striking amount of white matter disease, no strong risk of bleeding that's evident, and went on therapy. After therapy, you can see a small area of brain edema, maybe a small area of hemorrhage. These things tend to occur together, as you'll learn. At 8 weeks, they stayed on therapy. At 8 weeks, we now have 3 microhemorrhages, maybe 4, and a slightly larger area of edema. And again, they frequently coexist, but you grade them separately when you do your grading and deciding how you want to move on. All right, here's another case from a friend, Rachel Gordon, out of RadNet. This patient actually had an FDG PET. As you've heard about FDG PET, it tends to be positive very late in this process. It reflects neurodegeneration. So this would have been read as normal, and it was. No sign of neurodegeneration, so the patient was going to be put on therapy. On this particular case, and you can see there's really nothing striking on this exam that looks like it would stand in the way of therapy. If you do a more sensitive scan to look for the presence of hemorrhage, you'll see that there are actually 2 areas of microhemorrhage. Now, we all know that SWI is more sensitive than GRE. GRE is a little easier to read, a little less complicated, hard to confuse a vein for an area of hemorrhage, but it is more sensitive. And another thing that I can see as a long-term big administrator, one of the things that gets rolled out most poorly is the SWI. We often don't see the minimum intensity projections process. There's poor understanding as to what these actually mean and how they're done. But on the raw image here and on the minimum intensity projection phase images here, actually I think it might be the other way around. These are phase images. This is the minimum intensity projection image. Just goes to show you there's a couple of hemorrhages. All right, so patient was allowed to go on therapy. First exam, 4 doses later, still asymptomatic. We now have an area of edema. It's a sizable area of edema that led to a temporary cessation in therapy. After a period of time, the patient came back, the edema had resolved and therapy began. Interestingly enough, there was a new incidental hemorrhage in the area where the edema was before. Again, nothing that stands in the way of therapy. We'll cover those rules in a moment. In general, the more powerful the drug, Kisunla is a little more powerful than Leqembi, the higher the complication. This will probably transit along as more of these agents get approved. But fortunately, the majority of these events are mild and self-limited. But more importantly than the few cases of severe reaction that you see here is that the risk is increased in these ApoE4 carriers, particularly the homozygotes, and that will come up in discussion. So again, MR is important now because it's important as an exclusion for therapy. It's also important now because it is used for surveillance for the complications that occur with mobilizing amyloid. And if you're using lecanemab, you're going to get 1 pre-scan and at least 3 post, unless of course you're at higher risk when you're going to get more. And clinical guidelines may lead to episodic screening, maybe at 6-month intervals. With donanemab, you end up with 1 pre and 4 surveillance MR exams for each after the 7th, all the way out to the 7th monthly dose. And you may screen at 6-month intervals, according to clinical guidelines. And again, if you have higher risk you will get more scans. All of this has led to the expected rise in brain MR volumes. This again is year-old data, just about the time that we were starting to screen for patients going on therapy. If you're not seeing these volumes, someone else is seeing them for you. It is critically important that we communicate well with our neurologists, and the neurologists communicate well with us for scheduling of these processes, and we have nice workflow pieces worked up, but also to communicate with the radiologist. It is a very difficult task to make the diagnosis of quantifying and detecting ARIA, but if you don't know you're looking for it, you're not going to be able to detect it. Now, how do we study these patients? We use a full study. When we were at RadNet, we use a traditional GRE. There's only one thing you need to worry about on the GRE, and that is, what the imaging, parameters are. In the interest of making prettier images, many of our technologists have taken the TE down below the point where the exam is useful. This is a 1.5 T scanner. It has a TE of 5, a very pretty image, but you can't see anything. Okay, if you use the appropriate parameters for a 1.5 T, where the TE is 25 to 30, look at this. You've got 1, 2, probably 3 hemorrhages. You missed them all. Okay, maybe you see that one in retrospect. So as an administrator for a big organization, please go back and check your own places. I personally will bet you $5 you will find at least one that has the wrong parameters. We still find them today. It is a difficult thing to find. Now, again, some people like to do SWI. It's more work. It's harder on the patient. It's a bit more confusing, but no one will argue with the fact that it's more sensitive. Okay, nobody will argue that. So the question is, if your referring physicians want the information, they want the greatest sensitivity, you give it to them, okay? But then it's kind of hard to determine in any given case dogmatically whether or not how you react to this. Now, again, our job in the last 6 minutes is to detect and quantify the findings of ARIA and classify it as either mild, moderate, or severe, looking for siderosis, microbleeds, and the edema that we talked about beforehand. Because our findings will determine whether or not therapy needs to be paused. When it comes to REE, the edema, if the findings are mild and there are no symptoms, which means one focus less than 5 centimeters, you continue on. If it's moderate or severe, as you can see the criteria here, you have to suspend dosing until the symptoms and the imaging resolves. For hemorrhage, you've got to look at siderosis and microbleeds. And again, if it's mild and there are no symptoms, you can continue on. If the findings are moderate or severe, you need to suspend dosing at least until the images become stable. Some examples from the literature. Pre-treatment, post-treatment, everybody sees that. What do? Where does it go? Mild, moderate, or severe? Well, this is a small single focus. It's mild. You can continue therapy. Very simple. A little more difficult case with a lot of baseline white matter disease. Detection might be more difficult, but here the guy's got 3 foci. Okay, how does that come out? Well, again, it's definitely multiple, so it definitely goes into the category where we have to pause and wait for that to resolve. All right, another case. This one has a little bit of edema, but also has 1, 2, 3, 4 microhemorrhages. What about ARIA hemorrhage? ARIA H, what do you do in this case? Well, with 4 or less, you can continue therapy. This patient had no bleeds beforehand, now has 1, 2, 3, 4, 5. Now, the point of pointing at all these little dots is because neuroradiologists have said to me, you mean I have to count dots? You mean that's suddenly important to this patient's treatment and therapy? And the answer is yes, you have to count the dots. And it's not easy, okay? But you have to do it. In this case, because there are 5 new hemorrhages, you need to pause therapy until this stabilizes. Again, people have died from these drugs. It is not innocuous. If it hasn't occurred to you yet, it should occur to you now. ARIA can be subtle and it's unfamiliar, and the significance of these findings is unfamiliar to us. We may not actually report them. The quantification must be standardized and consistent to get the best outcomes, and early literature suggests that we're really bad at this. Okay, and a commentary on a recent paper that I'll show you in a minute, it basically said, a use of an AI-driven tool is probably a good idea to assist us in this endeavor. That even ignores the fact that we're reading twice as many cases as we ever could beforehand and can give a lot less thought to any individual case. A recent paper looking at this application, which eventually achieved CAD-E and CAD-X in the diagnostic arena, you can see here, was published in the JAMA Network Open. It uses the cases from the Biogen clinical trials, and they used radiologists that were representative of what you might see in the real world. There were some cases that were concordant between the expert and the AI. AI on the right, expert on the left, pretty good concordance. No clinical relevance to any discrepancy. Again, good concordance between the AI and the expert. Okay, a little overcall, a little mismatching. There are also cases that were discordant, where the reader didn't detect that little area of white matter hyperintensity. You can see how difficult that might be. A bunch of little dots, and you're not focused in. You may miss the fact that these two weren't there before. The radiologist did. Or in this case, you might overcall, right? The radiologist called a bunch of hemorrhages here. I don't know that I really see those. At least the AI didn't think so. Missed one over here, and then this one diagnosed one there. So how did it do in this particular publication? Well, approximately 30% of the RAE and 30% of the RAH cases were missed by the radiologist. Most of these were mild, but a significant percentage, about 15%, were in the moderate or severe, which would have had an impact on therapy and theoretically risk. The tool improved sensitivity and specificity. Oh, I'm sorry, I didn't say that. I said that wrong. It improved sensitivity to RAE and RAH in this particular circumstance, particularly when the findings were mild. And you can see a significant improvement in the performance of the readers over the readers when they use this tool in conjunction. Now, my last slide or two, just to point out that, what makes a difference is when you shift from the mild to the moderate or severe category, because that is where you pause. That's where your risk theoretically is going to come in. So if you look, this is without the assistance, and you see the effect on these graphs. And you notice that when you go to assistant, there is a jump from one category to the other. I'm going to go back again. The jump back to the beginning. Okay. It's hard for me to do. That's the beginning, and this is after the findings. So moving from normal to mild and mild to moderate or severe, which has an impact on, again, treatment and theoretically risk. So I hope you enjoyed that basic technical introduction to the opportunities that we have here today, and the unique obligations that we in the radiology community, certainly the neuroradiology community, have to address the specific needs of these patients, to address the specific concerns of the neurologists and perhaps eventually geriatricians that send us these patients. And I think over the next hour and a half or so, you're going to be treated to some really special material, great case studies, and folks that are really living in the space and thinking and working with their clinicians in close proximity. So I'd like to thank you very much for your attention. And I, as you, will looking forward to the rest of this program.
Okay, we did a different study looking at gallbladder polyps that were imaged serially over time and found that patients' gallbladder polyps routinely fluctuate in size. They both grow and shrink 2 to 3 millimeters very commonly. And they can also change in visibility. Sometimes you'll see it, and then on a follow-up, you'll not see it. And then on a follow-up after that, you'll see it again. And so that's actually quite common. And so we feel like this is so common that if you use 2 millimeters as a threshold, 2 millimeter size change as a threshold to recommend cholecystectomy, that's way too conservative. You're going to be recommending way too many cholecystectomies. Okay, we also surveyed all of the fellows of the Society of Radiologists in Ultrasound, and we are all SRU fellows here, so I'm not biased or anything, but SRU is a really great society. I recommend all of you to join it. I've learned so much about ultrasound through this society, and within the society, the fellows are sort of like the luminaries, I would say, and have a lot of great experience and knowledge. And we asked them, have you ever encountered a pedunculated polyp that measures less than 10 millimeters in size that was followed and then later found to be malignant? How many of you have ever seen a sub-centimeter polyp that turned out to be cancer? Anyone in this room? Okay, nobody. All right, well, neither have 100% of the fellows of the SRU, which I was actually quite surprised by. I thought, well, maybe 1 or 2 people may have seen this once or twice in their life. That's fine, right? But I was actually quite surprised. 100% have never seen this. Using 10 millimeters as a size threshold for recommending surgery is actually controversial. We do this a lot. 10 millimeters is sort of like this threshold that we all use, like lymph node diameter, et cetera, and gallbladder polyps, for instance. But if you do use that 10 millimeter threshold to recommend cholecystectomy, that results in significant overtreatment of gallbladder polyps. And there's multiple studies that have shown this. In addition, the morbidity and mortality associated with a cholecystectomy, I mean, it's a pretty benign surgery, but there is some risk to the surgery. That risk of the surgery exceeds the risk of malignancy of a polyp that measures over 10 millimeters in size. Okay, so why are we aggressively following and treating gallbladder polyps? I've presented all of this data to you, right? So I just want to sort of dissect some of the data in the literature. And I think there's actually 3 problems with how we approach data in the literature versus gallbladder polyps and cancer. So the first is that we think about gallbladder cancer and risk factors for gallbladder cancer. And I'll just list what is commonly accepted for gallbladder cancer risks: age, ethnicity, gender, smoking, diabetes, obesity, gallstones, and PSC. So I just want to point out a few things here. First of all, a lot of these are just risk factors for any cancer, not just gallbladder cancer. Secondly, do you see gallbladder polyp in this list? No. Okay. So the other thing is that the risks, the things that increase your risk of gallbladder cancer are not the same as the risks of an individual polyp turning into cancer. So that's also different. With the exception of primary sclerosing cholangitis, which is kind of a different animal. These are patients who have an immune-mediated inflammatory or fibrotic process going on in their bile ducts that then leads to this biliary epithelium field defect. And so you are at increased risk of developing GI cancers, cholangiocarcinomas, and gallbladder cancers if you have primary sclerosing cholangitis. And so we do not want you to apply the SRU guidelines to these patients with PSC. There are 3 specialty guidelines that discuss PSC patients, and you can choose which one you prefer: AGA, EASL, or AASLD. Okay, so the second problem with the data and in the literature is that the risk of a gallbladder polyp in the literature is actually not the same as the risk of cancer in an individual incidentally detected gallbladder polyp. So let me explain this a little bit more. So I do a lot of research, and you do need a reference standard when you are comparing things. And with gallbladder polyps, we do like to have path correlation as a reference standard. But if you're doing that, then you introduce significant selection bias, because every patient needs to have undergone a cholecystectomy. And usually you don't do a cholecystectomy unless your polyp is over 10 millimeters. And so that will then exaggerate the proportion of polyp-associated malignancies. And so, it doesn't, it's not ethical to resect a gallbladder polyp just because you have it. Like there needs to be another reason. So it's really hard to do a study where you actually have incidentally detected gallbladder polyps. So it turns out we use a lot of data from gallbladder polyps that are over 10 millimeters, and you cannot actually extrapolate that data and then apply them to sub-centimeter gallbladder polyps that are incidentally seen. Okay, we also know that we can safely ignore gallbladder polyps that are less than 5 to 6 millimeters in size. There was this meta-analysis from 2014 that showed no cancers in polyps less than or equal to 5 millimeters, another in 2015 that showed the same thing, another in 2016 that showed the same thing. There's this paper that was published in 2011 by Michael Corwin et al. And this is a paper that has had a lot of impact. So I'm going to come back to this paper in a little bit. But they found that 69% of polyps less than 5 to 6 millimeters seen on ultrasound had no path correlate at cholecystectomy. Like, what happened to them? We don't know. We think that maybe they kind of twist off, or they're just not seen by the pathologist. But there's another study that also showed that polyps in their study, this is from MGH, less than or equal to 5 millimeters, had no polyp in 83% seen on pathologic evaluation. So these little guys, I think our pathologists are actually not seeing. Okay, and then the final problem with how we look at the data is that there are some studies out there that equate neoplastic polyps to cancer, but that's actually not correct, because we don't know what is the true incidence of the carcinoma risk of adenomas. That adenoma carcinoma pathway is not clear with gallbladder polyps, and we think that is actually quite low. Okay, so those are some of the data and some of the reasons why it's a little bit of a conundrum of how to deal with gallbladder polyps. So taking all of that data, we applied all of that and then came up with our SRU consensus conference recommendations for incidentally detected gallbladder polyps, which we published in Radiology in 2022. And if you have not read this paper, here's the QR code. It'll take you right to it. It's free access. It was published in July of 2022. And we're so excited that just a month later, it was the #1 downloaded paper in Radiology. And it was listed as one of the top 5 reviews in 2022, in addition to Bill's paper, where he talked about soft tissue masses. This is our paper on gallbladder polyps. And so now it's been downloaded over 230,000 times. So I was the chair of this consensus conference, and I invited experts in hepatobiliary imaging from across the country, including Michael Corwin, who's the author of that 2011 paper. We had experts in surgery, in hepatobiliary malignancies. I also invited John Luke Zukowski. He's the author of that 2020 paper from JAMA. He was one of our gastroenterology specialists, and we had some pathologists with expertise in this area and a sonographer. So before you apply the SRU guidelines, we want you to go through this flowchart and make sure that you are applying it to the right patient. So first of all, if you see a gallbladder polyp on ultrasound, you want to make sure that you can see the gallbladder polyp. And if you can't see it that well, there's something like maybe the gallbladder's not well distended, then you could do a repeat ultrasound in 1 to 2 months with improved technique to relook at that gallbladder polyp. If you're looking at what you think is a polyp, but you're not sure, is it a polyp? Is it a sludge over 10 millimeters in size, or is it adenomyomatosis? Then you could either do a repeat ultrasound or CUS or MRI for further characterization. If there is suspicion for malignancy or invasive tumor, then don't use the SRU guidelines. Refer the patient to an oncologic specialist. If the patient has PSC, then don't use the SRU guidelines. Use the GI specialty guidelines, which I talked about earlier. Otherwise, use the SRU algorithm. Okay, so this is our algorithm on a single page. We did this on purpose so that you can like print it out and put on your wall. And I have to admit that sometimes I don't even remember every specific detail in this. So it's nice to have this on your wall if you are reading ultrasounds. And we divide gallbladder polyps into 3 categories: extremely low risk, and indeterminate risk based on morphology. And then we further subdivide based on size to get to our recommendations. So let's go through this in a little bit more detail. Okay, so the first category is extremely low risk. And this is where you have a gallbladder polyp that is has either a ball on the wall configuration where you have a ball resting on a flat surface, or a pedunculated polyp with a thin stalk. So I just want to point out a few things here. Ball on the wall. How many of you like ball on the wall? Some people on our consensus conference were like, that is too colloquial. But I was like, I like it. It rhymes. Ball on the wall. Like Ayakomaya rhymes. Right? So ball on the wall it is. And so yeah, ball on the wall. Another thing that we ran into is that there are hyphens here. Ball on the wall. This is thanks to Bill. He was like, there are hyphens. So I had to go through the whole paper and put hyphens. That was a lot of work. Okay, and then the other thing is it's not ball on wall or balls to the wall. It is ball on the wall, like the wall. So, get it right. Okay. The other thing I want to point out is it's extremely low risk. Some people are like, oh, is it very low risk? I'm like, no, it's extremely low risk. So, because, we're trying to figure out like, how can we convey how extremely low the risk of malignancy is? Extremely low risk. Okay, so that's what this is. If you have an extremely low risk gallbladder polyp, we can ignore up to 9 millimeters in size. Also, round to the nearest millimeter, no follow-up. Okay, 10 to 14 millimeters, follow-up at 6, 12, and 24 months. Greater than or equal to 15 millimeters, surgical consult. So that's a little bit larger than your typical cholesterol polyp at that point. Low risk is the middle category, and this is where you either have a pedunculated polyp with a thick or broad stalk connection to the wall, or a sessile, dome-shaped, or flat configuration. For these, we lower our thresholds a little bit to 6 millimeters or less, no follow-up. 7 to 9 millimeters, one follow-up at 12 months. 10 to 14 millimeters, follow-up at 6, 12, 24, and 36 months, versus if there's something about it that you don't really like, or, there is, surgical consult is a reasonable alternative at this point. And then 15 millimeters or greater, surgical consult. The final category is indeterminate risk. We've done some studies, and we found that this is actually a pretty rare category to utilize. Not that many polyps fall into this, but you do want to be looking out for this, which is defined as, it's not so much the gallbladder polyp, but it's the adjacent focal wall thickening, where that wall thickening is greater than or equal to 4 millimeters. One thing I want to point out here is it's indeterminate, not intermediate, indeterminate. Some people get that confused. Okay, so for these, we do not ignore any of them. If it's 6 millimeters or smaller, the polyp itself, then we recommend either follow-up in 6, 12, 24, and 36 months, or surgical consult. Or if it's greater than or equal to 7 millimeters, the polyp, then surgical consult. These are a little bit more concerning. Okay, we are following some polyps so that we can evaluate for growth. Growth is defined as an increase of 4 millimeters or more within 12 months, or a growth to 15 millimeters if you are extremely low or low risk, or 7 millimeters if you're indeterminate. And for those, if you meet those criteria, then we would recommend surgical consult at that time. But if you're following it, and the gallbladder polyp or polyps, and they shrink more than 4 millimeters, 4 millimeters or more, or stay stable over the follow-up period, then you can ignore and stop following those polyps. If you're like, I'm not sure which category this falls into, or I only want, I'm not sure, then you use the low risk category. Okay, so we basically stratify gallbladder polyps based on shape, then further stratify based on size. With some polyps, we are looking at growth, which is determined with follow-up. And we do feel that 3 years maximum is sufficient to identify the vast majority of polyp-associated malignancies. And I do want to say that this is our first recommendations, and there's a lot of data that can be accrued based on this. And I encourage all of you to do research, because it's with data and research that we can make improvements on our recommendations. So that's really critical. So let me just show some studies that have been published since our recommendations have come out. So Avinash's group at MGB, they looked at how the intermediate agreement is, and he found that it was substantial for polyp risk categorization and surgical consultation recommendations. We did a study at Stanford looking at the costs associated with follow-up of gallbladder polyps and surgical resections, and we found that the SRU guidelines actually result in a 97% cost reduction compared to the European guidelines, and 86% cost reduction compared to the ACR guidelines, without compromising sensitivity for detection of gallbladder cancer. Okay, so I'm going to move on to examples where you can practice using the SRU guidelines. Okay, so first of all, this is a first example, 14 millimeter gallbladder polyp. So it kind of has that flat look, so we put it in the low risk category. It's 14 millimeters. And so for this one, it's we would recommend a follow-up at 6, 12, 24, and 36 months versus surgical consult. Here's another example. This is a 1.6 centimeter gallbladder polyp. Kind of has this, looks like a football, ball on the wall, I guess, appearance, but it's kind of big, 1.6. You want to use the longest dimension. But it's got some vascularity. Does that change your category? No. Okay. We looked at vascularity in the literature to see if, can we use vascularity? I was hoping that we could, but it turns out that there isn't strong enough evidence right now. Maybe there will be, and I encourage all of you to do that study, because that would really help us. But right now, the evidence is not strong enough. So anyway, 1.6 centimeters. It does have this football look to it, so it is extremely low risk, but it's kind of big. So it's over 15 millimeters. And so for this, we would recommend a surgical consultation. Okay, next we have a 7 millimeter sessile polyp. Here it's measuring 0.65. go back to your math in middle school, or forget where you like learn how to round, right? So 0.65 is rounded to the nearest millimeter, so it's 7. It is sessile. And so we put this in the low risk category. And so for this one, follow up at 12 months. Okay, next, 6 millimeter ball on the wall polyp. So that is pretty easy, I think, extremely low risk, and it's under 9 millimeters, so no follow-up. Here's one. Which one would you put this in? It looks like a lucky clover leaf, and it's got 3 sides, but because it doesn't fit, we would use a low risk. It doesn't quite, you don't have to spend too much time trying to decide if you can't tell. So low risk, it is 8 millimeters, follow-up in 12 months. Here's one, 30 millimeters. That's very big, right? It's got a very broad base. This is thanks to Bill. So at this point, you're like, wait, that's not a polyp, that's a mass. Okay, well, it doesn't matter. It's 30 millimeters. That's way too big. It doesn't matter which category you put it in. In any case, it would go to surgical consultation. Okay, last example, 77-year-old with 2.5 centimeter polypoid lesion on CT. Some people ask me, can you apply the SRE guidelines on CT? And I will say that we did not intend for it to be on CT. We intended it for ultrasound, but nonetheless, here is a 2.5 centimeter. There's actually multiple masses, lots of wall thickening here. And so in this case, this is actually quite concerning for cancer. And so we would say refer to an oncologic specialist. Okay, so going back to our original patient, 7 millimeter gallbladder polyp in a 61-year-old woman. How many of you would recommend no follow-up? Okay, most of the audience here. How many of you would recommend a repeat ultrasound in 6 months? Nobody. Okay, how many of you would recommend a repeat ultrasound in 1 year? Nobody. Okay, how many of you would recommend surgical resection? Nobody. Oh my goodness. Wow, I've convinced you. Okay, good. So it looks like a ball on the wall, extremely low risk category, less than 9 millimeters. So yes, if you're using the SRE guidelines, no follow-up. So the SRE guidelines have recommendations incorporates evidence-based and expert consensus-based recommendations for management of incidentally detected gallbladder polyps, where we take into account shape, size, and growth. So thank you so much for your attention.
If they're 30 seconds faster, you think, well, that was a good decision. You run a red light and have a collision, and say, well, that was a really bad decision. It was the same bad decision both times. It doesn't change it because the outcome was different. Overconfidence, we all suffer from this from time to time. But I love to say this quote, the great Osler, he said, there's only 2 kinds of doctors, the underconfident and the overconfident. It's very hard to get that right. Pro-innovation bias is really coming up a lot now in the AI era. And salience bias, the most easily recognizable features are the ones we focus on. Excuse me. Anyway, most of these biases are not conscious. They operate below the level of conscious awareness. And that's why overcoming them can be very challenging. You almost have to stop and say, wait a minute, am I jumping to a conclusion here? Am I succumbing to a bias? In the legal context is adversarial. And Dr. Waite made this point. Every side is seeking a particular outcome. Now, we are trained in a different culture to utilize a scientific method, and we're trying to weigh lots of different evidence and sort of model objective truth to as impartially as possible. So basically, this is the difference between air-breathing mammals and fish. They're in a different milieu, and we have to keep that in mind. So there's a challenge, to maintain impartiality and objectivity in this. And attorneys will often press an expert to frame your opinions in a way that suits, their case, as Dr. Waite mentioned, and ask you to say, well, doctor, can you say that this is to a high degree of medical certainty? Well, what does that mean? And they also try to frame the discussion in ways that favor their desired outcome. And that can be selectively presenting which facts, or as Dr. Shepard said, narrowing the focus of time to a single millisecond. To try to deal with that, and asserting a greater amount of certainty. Again, we live in a world of uncertainty, but often the attorneys will try to put more certainty on it than the facts can truly support. And certainty is very elusive. Uncertainty is the defining feature of the world we live in. And this is a great new book by David Spiegelhalter. I had the privilege of getting to know him. He's from Cambridge University, and he wrote this book. One of the most fun books you'll ever read by a mathematician, by the way. So years prior, and no one can remember it. There's very limited threads of evidence left behind. And so both sides will try to frame the same evidence to support their desired conclusion. And subjective expert opinions are usually diametrically opposed. And so attorneys on both sides will try to exploit the cognitive biases of the experts and the jurors. The evidence that we ignore versus the evidence that we believe, and that can, based on the Venn diagram of what overlaps our existing beliefs and the facts and evidence. And a small number of biases exert an outsized impact. And as I mentioned, anchoring and other biases seem to have greater impact than others. And that's the Pareto principle. A minority of causes give you the majority of problems. So 4 main biases. The bias that failing to detect an abnormality in and of itself constitutes negligence, as the 2 previous speakers have pointed out. I believe that is false, but it is a bias. This is my opinion about it. The hindsight bias, where something seems obvious once shown, and so the person believes that they would have known it all along. Of course. And the classic example of that, which I've actually explained to jurors from the witness stand, is that you imagine you're watching Jeopardy, and the contestant comes up with something that you would never have thought of in a million years, but it's right, and then you sort of convince yourself, oh yeah, I knew that. I knew the headwaters of the Nile. And the nice example of that is we've all seen this logo something like 1 million times. And if you drive around, you see it. How many people have noticed there's an arrow built into the logo? A left to right arrow. Of course, once you've seen it, you can't unsee it. You're going to see it every day now. You're going to see this 1 million times. You're going to see this arrow. Every time you see this, you're going to and you can convince yourself, oh yeah, I knew that all along. But if you're honest, you probably didn't notice that before. So the outcome bias, I already talked about. The severity of an error is judged by the outcome, which of course could not have been anticipated. And Dr. Waite made the point that, don't tell me all this stuff. I just want to know what the radiologist knew when he had this case. And I only want to spend about as much time as he did. Gambling is a great example. Like if you win at the craps table, does that mean that gambling is a great way to make a living? The outcome. The other thing is the halo effect. This is another of the main biases, I think, that really comes into play. And I was actually asked in a court of law, Dr. Bruno, do you disagree with the great Wahuda from Harvard? He's from Harvard. I said, yes. I said, respectfully, I do. But they know that the juries have biases too, and one of them is a halo effect, and they tend to think that people like Brian Shepard, who's the dean of a law school and is trained at Harvard Law School, he's smarter than me, so I'm going to go with you. So, here's the Harvard diploma, not to pick on. But anyway, like they say on the airline, get your own mask in place first. Debias yourself first, and then only then try to help others. And as Brian said, the new standard of law, as law evolves, is going to involve more evidence. and drawing on scientific evidence, because without data, you're just another person with an opinion. And as you've already heard, AI will likely make things worse, not better, because of automation bias and other biases that people have. There's a lot of magical thinking about AI. But Dr. Baird and others have been exploring that and finding out that if you give juries more information, they actually can figure it out. And I've had very encouraging results that will restore your faith in humanity, that if you really take the time to explain things to a jury and help them to understand that they will make reasonable decisions. But AI at least has the possibility of making things worse. Dr. Banja and I published a paper on this a long time ago. You know, basically it can be a double-edged sword. The plaintiffs can say, well, doctor, you know that the AI is right most of the time. Why did you disagree with it? Or they can say, well, doctor, you know these things aren't always right. Why did you go along with it? So you can be turned into a piñata either way. So I think that ultimately it may make things better because if it reduces patient harm, then there'll be fewer lawsuits. But in the short run, it may make things worse. And remember, HAL 9000 was one of the first AIs, and of course, it was a homicidal maniac. And Steve said this, and I think it's really true. You know, sometimes you're not going to be able to bridge the gap between what the attorney who's consulted you wants you to say and what the facts of the case are, and you just have to walk away. How hard can that be? It can be hard, and it's especially hard if you find yourself as a faculty member in an academic institution where your salary is less than the actual cost of living in the city where it is. I could name a couple, but I won't because I'll be showing my biases. And then you have more financial pressure. Of course, if you live in idyllic Hershey, which you know has one of the lowest costs of living of any place in America, you feel less of that pressure. So we have dealt with things. I see this all the time, where the hired gun, the rogue expert witness, the person who will just say anything. They tend to be more on the plaintiff's side, although not exclusively. And that's because there's, Dr. Waite talked about how it's typical to bill like between $450 and $500 an hour. That's the defense side, because that's what the insurance companies will pay. When you're on the defense side, you're working for the insurance company. When you're on the plaintiff side, you're actually working for an entrepreneur, and you can ask them for anything. And I've seen, because they ask this in courts, and it's on the deposition transcripts, where the plaintiff's expert is making $12,000 or $15,000, and I'm probably going to bill $1,200 by the time the case is over. So there's a big differential in that. So some people need the money, and they will say anything to get it. And like Steve was talking about, the guy who's qualified as an expert in everything. We do a very bad job at policing these rogue expert witnesses. And the American College of Radiology had an ethics committee that was doing that. When I asked them about a case, they said, oh, no, we can't go after that guy. There's just no teeth to it. We don't act like a guild that polices itself. And this is a huge problem. More than tort reform, I think we need sort of guardrails around expert witnesses, that the testimony they give should be based as much as possible on existing evidence and facts. There is an ACR practice parameter on the physician expert witness in radiology and radiation oncology. It's a very nice document. I encourage you to look at it. It specifies a number of things, and things that Steve has already talked about, like, you're not joining the advocacy team for one side or the other, that you're there as a friend of the court to tell the jury and the judge the facts and help them understand things that are too complicated for them to understand because they haven't spent their entire decade of their 20s learning these things. So, that is a very, very nice document. We don't enforce it, but it's there. Number 9, I think it's good to embrace humility. And we all know that when it comes to making errors, who makes errors? We all do. And, humility is a result of self-awareness. I think it's really the essence of empathy. And you don't want to be overly arrogant about these things. And it's good to have compassion for yourself and others when you make a mistake. And I think that's very important. It's not the same as self-esteem. We're not all getting a purple ribbon for showing up. Number 10, I believe that there is objective good in the world, and ice cream is an example. So we're going to have some questions at the end. I'll put that off for now. And it's very important to move on to the last word. I want to give the last word to Dr. John Banja, Professor of Ethics at Emory University, who's going to talk to us about the ethics of all this. And I hope you
professional fulfillment and burnout. And I sent out invitations to randomly members of our community who I thought may be interested. And I selected 7 faculty members for each cohort. So I had 21 physicians being part of this pilot initiative. And they were diverse in terms of gender, career level, and the vision. So these 3 cohorts met for dinner every other month for 6 months. So each cohort met 3 times. I was a facilitator. I'm not trained, but I did come with predetermined discussion questions and topics that we talked for 10 to 15 minutes about. And then we spent the remaining time enjoying each other's company, talking about day-to-day things, getting to know each other, deepening relationships. And I chose a variety of cuisines, whether it was Italian or Greek or ramen, in a comfortable, cozy environment. And I really want to stress the importance of a round table. It really makes for great conversation. And then I wanted to be respectful of people's time. I limited it to 5:30 to 7, and I always had a dessert treat, a wrap treat with a commensality quote, or something about wellness, or a Greek philosopher who had a wise saying, to leave people with food for thought and to enjoy with their families. So leaders should consider beginning dinners with positivity. You want to go around the table with personal updates, share one good thing, have discussion questions that have a positive vibe, and ensure that everyone has the opportunity to speak and feel comfortable. There is an importance to psychological safety and feeling like you could speak and be honest. This is the one picture that I wanted to show you, that the one dinner of the 9 dinners that we had a rectangular table, and I do feel like that was the least successful. There were some side conversation, not everyone was always included, and it really is important if you can get a round table to just get together. Questions for discussion that I talked about: what gives you meaning at work right now? What keeps you energized and fresh to experience personal growth? What does appreciation mean to you? And how do you connect with colleagues? I had results that came out pretty positive, knowing that we had a small sample size and the current events going around, that there was a statistically significant reduction in burnout following this intervention, and increased trend in towards career satisfaction. So otherwise, people would send me comments, unprompted and unsolicited comments, what I've enjoyed. And they said, I really enjoyed meeting everyone, looking forward to the next dinner. The commensality dinner worked. I saw Dr. X at the radiology party, and she introduced me to other attendings, and I felt warm welcomed into the community. I wanted to let you know how great it was to spend time to connect with colleagues. And really, it was wonderful what you've created. So I do think that was successful. The challenges, there were some challenges faced. Obviously, I gave everyone the first date to make sure they were able to attend. But after that, I set up a doodle poll. I really wanted 100% attendance, and overall, we had 100% attendance, except round 2 of dinners, where in January it was cold, and 1 to 2 physicians were unable to attend. These are last-minute cancellations due to sickness, family plans, last-minute clinical coverage. But again, this was not supposed to be stressful. I did not want anyone to feel burned out. So I did want everyone to feel that it was okay if they missed the session. Colleagues also heard about the initiative and questioned why they weren't included. So that made me feel like, oh, more people want to be involved. And I said, this is just an initiative, and hopefully we can spread the word and keep going. There were senior colleagues and male colleagues who were less likely to respond yes to the commensality project. So the future of commensality, goals for the future, maybe implementing it annually within the department, allowing people to sign up, or not targeting just the social people, sending invitations so that non-social people will join the events as well, or people that are less social, and expanding it interdepartmentally to surgeons and radiation oncologists, nuclear medicine and pathology, and maybe even having institutional commensality events where we can meet people within our region. So I just want to leave you with this quote from the former Surgeon General, Dr. Vivek Mukherjee. Each of us can start now in our own lives by strengthening our connections and relationships. We can build lives and communities that are healthier and happier. And this is a piece of art that called Togetherness. by a Nigerian artist. And it just, I want to sum it up by saying that our thoughts can come together. We can build teamwork and camaraderie and share thoughts of happy feelings as well. So thank you very much.
That you have in your paper. They should be, of course, well organized, clean, and meaningful, not redundant. They should tie into the content of the article. And it's always important to triple check for accuracy, especially when you have a lot of information. They are a popular tool for presenting different sequences, for instance. But here we have one where it's essentially a summary of the paper, where you can see, in this case, applications of ferriomoxitol enhanced MRI in clinical research and practice. On the left side, you can see the different applications, and here on the right, you can see what the current status is, and the authors also provide different references for you to do further reading if desired. And of course, as radiologists, figures are important. You have to use them wisely. They have to be relevant to the study. They have to tie into what you're trying to tell in your narrative. And of course, you should strive to include images that are high quality, that they don't have a lot of artifact. Schematics and diagrams are valuable in some types of topics. And labels and arrows are also important, because you are the expert on the paper. You might know the topic very well, but for some of the readers, the findings may not be obvious as they are to you. And also remember that when you're working with a figure, that will be processed and minimized and in the final publication. So keep that in mind when you decide on your labels. But labels are important. Also try to focus on the relevant aspects of the figure. Try to avoid dead space, unwanted areas. Here is one that is nicely cropped, and you don't have unnecessary information. Everything is nicely labeled. You can see the finding very well. And here you can see a zoomed in section of the area of interest. You have sufficient anatomy so that you can orient yourself where you are, but you don't have a lot of unnecessary information, which makes it more representative. Flowcharts can help the reader understand and analyze complex procedures and workflows. So that's something that you can utilize if it's relevant to your paper. And finally, if you have schematic illustrations, that may help increase the visual appeal of your paper, and especially complex topics. That might be useful if it's applicable to your topic. So, and just to finalize, the guidelines were made the same. There were some differences previously, but now the guidelines for review articles and for clinical perspective articles are the same. You can refer to those from our website. So, in conclusion, what are we looking for in review articles and clinical perspective articles? We're looking for high quality articles that are impactful, that are clinically relevant, clinically oriented, innovative, state-of-the-art topics, emerging topics, and new updates. Aim for including an expert collaborative team. Remember the value of multidisciplinary teams, and also of multi-institutional authorship as well. And in essence, we're looking for content that will have the highest quality of supporting references, tables, and figures. And I will end here, and I appreciate your attention. Thank you.
And we measure the distance of the anticipated valve to the coronary arteries. For example, for the right coronary artery, there's no problem. There's 6 millimeters to the right coronary artery, but look at the left main, there's only 2.3 millimeters. So that's important, because it's a risk for coronary occlusion. So the considerations to have, as we know, there's two kinds of valves, the porcine valves and the pericardial valves. Usually when patients have a porcine valve, the true inner diameter is 2 millimeters less than the reported diameter. And when we have pericardial valves, it depends on the leaflets. If it's mounted inside of the rigid scaffold, or if the leaflets are mounted outside. So if the leaflets are mounted inside, the true inner diameter is 1 millimeter than the reported stent inner diameter. And if the leaflets are mounted outside, the true inner is similar to the reported inner diameter. So I know that is a little bit confusing, but in this paper, they help us to know the type of the valve, looking at the 3D images of the CTA. So that's how we can look at what kind of valve are these. So also, the type of valve is important. If it's stented, of course, we need to look at the coronary ostium. And as I told you, if the stent is above the coronary ostium, no risk of coronary occlusion. So we don't need to do the BTC measurement. But if the coronary ostium is below the stents, the post stents, we need to assess this. And if the patient have a stentless, we need to do the same protocol as a native aortic valve. So now move on to the complications that we can see after the TAVI. Also, we look at we can see this in biological prosthetic valve, surgical prosthetic valve. But maybe you hear before about HALT or HAM. HALT means hypoattenuating leaflet thickening, and HAM means hypoattenuating affecting motion. Both usually are in the same patient. So HALT basically means thickening due to thrombosis of the leaflet. And we have some examples here of this, the same paper of Dr. Blank. And we can see less than 25% in self-expandable and balloon expandable devices. And here, more than 75%. So this is the grading of the HALT. And this is one of our cases. We can see very little HALT, maybe 25% of HALT, but also there can be degenerative calcifications that affect the motion. This patient was with a lot of calcifications of the TAVI valve. Other complications that they show us, like in another paper, you can see the device deployment was below the level of the valve, and you can see the native leaflets are protruding above the level of the device. And here the device was deployed in a very calcified aortic valve, and you can see there's no wide open in the device. So there's a lot of complications that can happen in different scenarios. So in this book, they show us how to assess the different complications of the after TAVI. And as you can see, usually transthoracic echocardiogram is the first modality of choice, but CT can help us to assess paravalvular leaks or these HALT complications. So this is the summary of the recommendations. I don't want to spend a lot of time of this, but you can take a picture and take it home. But basically, post-TAVR, no routine CT imaging is recommended. And for valve-in-valve protocol, it's important to do the measurements of the BRT that I showed you before. So in conclusion, imaging plays a crucial role in patient selection, treatment planning, and device selection and position. And CT angiography is the gold standard in pre-TAVR protocol. Echocardiogram is the first modality to choose in the follow-up of these patients. and CT is complementary in the follow-up of this to look at the complications. Thank you very much.
Leader allows you to have a person who is got the interest and the responsibilities of the remote group in their head and nothing else. So they're actually really focused on, they need to have time to do X. They need to have great connectivity. They need to have the ability to interact with others, have quick communications with other people, really more focused on what their needs are, as opposed to me, who was a main campus person and a proceduralist, who had my areas of interest in, my focus on other things. I'm going to stop here for 1 second. I did have to skip a couple slides. IT is critical. If you have remote people, you want somebody to quit, go down. You want somebody to be unhappy, have your systems be slow. You want to have somebody who's really going to come and find my house and start throwing eggs at it, have connections that don't work correctly. You need to have both on-site hardware and software that's capable of actually making the experience as similar to on-site as possible. And we have all of those systems. It took a lot of work to get all of them. It took years of work to get them, but we do have that and have redundancy. That's a critically important aspect of it. So in conclusion, really engagement is important. I think we did a pretty good job of what the AI bot told me to do. We've gotten leadership involved. We've got a lot of opportunities for them to be involved in different meetings, opportunities to engage with other people, and then the technology part of it, I think we also did a pretty good job of. Are we perfect? By no stretch of the imagination. Is everything going to change again in the next 6 months? Absolutely. But at least right now, this is where we are. Thanks. All right. Thank you, Jay.
Thank you, Bill, for that wonderful talk. I am Jay Parikh, and I'm from University of Texas MD Anderson Cancer Center, and I'm delighted to be here. I have no relevant conflicts to disclose. I guess I kind of wish I did. You know, in terms of the next 10 minutes or so, I'll try and make it less actually, so we'll have time for questions. We're going to look at strategies to actually retain radiologists. Just curious, before we start, how many of you right now in your practice have a posting and looking to hire a radiologist? Okay. How many of you are not? We have one. Okay, lucky you. We definitely are. So let's look a little bit at the landscape. And I want to emphasize that this is not a new problem. We think that it is, but it's not. We know from 2002 to 16, we're going to first of all look at imaging volumes, and then we're going to look at transitions. From 2002 to 2016, the annual growth of imaging of ultrasound, CT, and MRI already was increasing 1 to 5%. Imaging volumes in the emergency department are continuing to rise, not to mention the number of images per study has risen repeatedly, and we have an aging population with increased healthcare needs, so the demand on actual imaging is going to increase and continues to increase. One of the things we need to look at, though, is the radiologists themselves, their dynamics in terms of workflows. The 1-year separation rate actually increased in the pre-COVID era. We weren't paying attention to it, but it went up from 13.8% in 2015 to almost 20% by 2018. Then we had the Great Resignation during COVID, where, depending on the literature you read, about 20% of the US healthcare workforce resigned. COVID also accelerated the teleradiology workforce, which has definitely impacted the way we do things. And there are job listings everywhere. In 2024, there were over 1,700 job listings. I just spoke at the Society of Breast Imaging, where there's over 300 job listings now in the SBI. There is no shortage of work out there, and people are moving. So if you want to retain your practice strength, you have to do things to try and stop the leakage, right? That's how we're going to survive. That should be priority number one. Rather than working on recruitment, is actually keeping the people you have and valuing your human capital. So briefly, we're going to talk about burnout. I'm going to look at burnout from the scientific point of view and definition. Burnout is very significant. It is a syndrome that has been defined now and accepted by the World Health Organization, resulting from chronic workplace stress. And notice the emphasis on the occupational context that is unsuccessfully managed. Multiple peer-reviewed studies have been carried out that have looked at the prevalence of burnout across multiple subspecialties in radiology, with the range being between 50 to 80% in these studies, some of the early work, showing that burnout is very prevalent. One of the things with burnout you can do, though, because it's scientifically defined, is look at associations and links. And one of the important things to understand, and this is a landmark study that was published in JACR in 2021, and this looked at over 450 radiologists in the Physician Wellness Academic Consortium in the United States. But using their models of measurement, there was a prevalence of burnout of 37%. But the intention to leave amongst the radiologists who actually did this survey was 1 out of 3, 33.3%. And the intentional leave was significantly higher, over double, in those who were burnt out versus those that were not, 51% versus 24%. So if we do things to help manage burnout, we can potentially help intentional leave and preserve radiologists in our practice. That's the mindset. This is actually a model that's been adapted by the AMA. If we assume a radiologist has meaning at work, there are 6 primary drivers of burnout: workload, control, work-life integration, social support, organizational culture, and efficiency and resources. If they're less optimal, the scale tips towards burnout. However, notice that if we actually increase vigor, dedication, and absorption into the practice, we shift the conversation and the narrative towards engagement. How do we actually move the needle towards professional fulfillment? And we have to thank the people from Stanford who came up with this model. Professional fulfillment, just to be really clear, can be defined as the perception of either having reached one's most important career goals, or at least a positive evaluation of being on the right path to achieving that. Using that as a core tenet of what we're going to call fulfillment, there are 3 components to achieving fulfillment: culture of wellness, efficiency of practice, and personal resilience. Now, for years, the radiologists and physicians have been actually labeled as responsible for the burnout because of the resilience issues. I just want to quickly dismiss that. A really nice study that was carried out by Colin West and colleagues from the Mayo Clinic looked at over 5,000 physicians across the country and looked at resilience scores using objective metrics in physicians compared to the general US population. And physicians repeatedly had higher resilience scores, which makes sense, right? If you think about the brutality of med school, internship, residency, fellowship for those of us who are fellowship trained, and then all of a sudden, oh yeah, you lose your resilience and you become burned out. It never really made intuitive sense to begin with. And higher resilience scores in physicians were associated with lower burnout rates, but even the most resilient physicians had substantial rates of burnout. That tells us that the conversation and the narrative needs to move beyond the individual physician to looking at system-level issues. What I'm talking about is redesigning processes and stop trying to redesign our physicians if we really want to make a long-term impact. So with that, let's look at culture as one of the 3 components. Culture is your soul. It's who you are. If you took a blood test of everybody in your group, that should be your culture test, your litmus test. And what we need to do as a specialty is to start to move the mantra. For years as an operational leader, I was trained heavily during my business training that no margin meant no mission. The practices that are doing well now have shifted and understand that there's no people, there's no mission. How do we actually implement a culture that's going to make a change in terms of the radiologists that we have? First of all, professional development is an important step. Important study from the Mayo Clinic carried out in 2009 in Archives of Internal Medicine showed that if a physician spends 20% of their time doing something they find fulfilling, they're less likely to be burned out. 20%. That doesn't always necessarily mean research or teaching. It can be things like philanthropy, being able to be engaged in nonprofits, Boy Scout movements, whatever it is that actually fulfills them. And actually getting to learn your physicians and spend time with them and being able to have them focus on things that they find actually helpful can make the difference. Secondly, I want to talk about self-care. Now, I know in this audience and historically when we talk about self-care, it's not always well received, kind of seen as foo-foo, but I'm going to tell you it matters. And this is in our own cohort. One of the hardest cohorts to actually scientifically evaluate in this country is private practice radiologists. And we have to thank Strategic Radiology, who for no other reason, which is a consortium of 31 private practice radiology groups, accepted this test, this survey data and test to look at actually the burnout prevalence. What they found is the burnout rate was about 46%. And these are people in the trenches, not leaders. And radiologists to call were more likely to be burnt out. Well, that's kind of intuitive. Also intuitive is that there was an inverse association between fulfillment and burnout, which is intuitive. Unfortunately, only about a quarter of radiologists in private practice currently feel like they're professionally fulfilled. What was very surprising to us, though, is that there was statistically associated increased professional fulfillment with eating nutritious meals and exercising at least 4 times a week. So the stuff that we've talked about for years, self-care and self-evaluation, it really does matter. Social connectivity has already been explained eloquently by Dr. Reichman, so I won't repeat it. But remember, humans have a fundamental need to connect. Also, I also want to emphasize that recognition is an important leadership tool, not because we are trying to stroke physician egos. More importantly, we're trying to create a sense of acceptance for radiologists in the group. Next, I want to talk a little bit about operations, just briefly in terms of some of the things that contribute to actually helping reducing burnout and potentially helping retain your radiologist. Number one, manage workload. Multiple studies have shown workload is the main source of stress for multiple groups in radiology, including breast radiologists. Historically, we see graphs like this, which talk about, oh, if you increase efficiency, that you improve quality and speed, and you reduce cost. Couple things though, speed kills. It doesn't matter if you're talking about driving a car, driving a truck, or reading mammograms or reading chest CTs too fast. You're going to miss the faster you read. And the other thing I want to talk about is now that there's increasing literature and finally people are having the courage to talk about this, is the downsides of efficiency. The antidote to burnout may not just be improved professionalism, but actually slack. Creativity lives in the slack space. I noticed before the majority of radiologists here in academics, most of your higher thought, your ability to have that serendipity that we talked about at the morning session, is to live in that space where you're not feeling pressure around you all the time. Academics, and I would argue even science, depends on us having slack space. The untold truth that nobody wants to admit and acknowledge is there is such a thing as over-efficiency. You can only go so many times faster on the hamster wheel before you fall. And these are some of the other strategies, making sure finances are looked after very appropriately, scheduling flexibility, support staffing, leverage IT, which Bill just talked about, Dr. Moore, so I'm not going to reiterate that. But I would like to talk a little bit about leadership and the increasing role we're seeing it having on our ability to be able to have successful practices. The Granddaddy study was carried out at the Mayo Clinic by Tate Shannonfield. They had over 2,800 physicians and scientists responded using validated tools to look at burnout and leadership qualities. And these are the qualities they asked people to think about with their leaders. Think about these questions. When they looked at the 12 questions, what they found was there was a 1-point increase in leadership score with a 3.3% decrease in likelihood of burnout and 9% increase in satisfaction. So the point here is the leadership qualities of physician supervisors appear to impact the well-being and satisfaction of individual physicians. There's actually a follow-up study to this, which you don't have the time to go into, that looked at 2-year follow-up, and the initial burnout that physicians initially experienced still happened 2 years later, and the organizational satisfaction decreased based on the initial supervision of the physician score. The leaders really matter from different contexts. Leaders are human. They can burn out too. What happens when they get burned out? Well, this is a nice study from Stanford, which showed that the higher the physicians were burnt out, the leaders were, the lower their leadership score when they were assessed by their followers. The more fulfilled the leaders were, the higher the leadership score. What does that mean? Every 1-point increase in burnout score of the leaders was associated with a decrement in their leadership behavior score. Burnout, professional fulfillment, and self-care practices of physician leaders were independently associated with their leadership effectiveness. So we have to start thinking about managing the leaders themselves. Leadership, whether we wanted to admit it or not, causes and cures burnout in radiology. We don't have time to look at these, but this is initial work, which I hope other institutions will follow at, where we actually formally trained leaders within our division of diagnostic imaging. And they looked at 5 core leadership skills. We had them look at emotional intelligence, self-care, resilience support, demonstrating care, and managing burnout as part of the 5 metrics that they were trained in. And then we looked at pre and post intervention of the training, of what happened to the faculty and what happened to the leaders. These were published independently in 2 peer-reviewed journals. And basically what we showed is that formal wellness training of academic radiology leaders led to improved teamwork scores of their faculty. Secondly, for the leaders themselves, it improved their work-life conflict. So we have another opportunity potentially to actually improve burnout and reduce intentional leave by actually training our leaders. I'll stop there. Thank you for your attention.
Okay, so hopefully I can build off of that and then build off of Ralph's talk earlier. So I'm going to be talking about retaining senior radiologists.
diagnosing for ARIA is based on FLAIR and GRE or SWI. So we need diffusion to rule out this other diagnosis. Okay. And so what makes it dangerous is you may be the only people who even know that this thing called ARIA exists in terms of that treatment team in the ER. Those teams are moving super fast. At our institution, when they show up by ambulance, they're not even like registered in the chart with their real name. They come in as some kind of weird doe. So even if she's getting infusions at our center, they may not know it at the time they're getting the head CT. And so like making sure that you're aware that this diagnosis exists, that your residents, that your trainees, if you have colleagues, so like us in some of our community hospitals, the people reading the overnight head CTs may normally practice MSK or body during the day. So making sure that all of your colleagues are aware of this when they're reading those head CTs matters a lot because they are going fast. And then these next two images, these surprised me a lot. So I showed this case to the neurologists last year at the big Alzheimer's convention. And they saw this color coding, and they saw this color coding, and they thought for sure this was a large vessel occlusion and a stroke, right? Because, we got the rapid AI tools and it's color coded, it must be positive for stroke. Well, you guys know what we're looking at, right? This is flagging the hypodensity, which is actually the vasogenic edema, not the cytotoxic edema. And, I don't know why it's flagging the right MCA here, to be honest with you. Maybe there's like a little bit of differential intensity of the signal, but, if depending on that team that's down there, you don't know, you in radiology, you're the ones who know how to interpret this, but they go on autopilot, they get these rapid reports, there's no filter, this person could have easily received TPA. Thankfully, she did not, because now you can see when you get the MRI, it's vasogenic edema, there's no restricted diffusion, and it's ARIA, it's not an infarct. And so just to let you guys know, there is now a consensus that came out just earlier this year in stroke with considerations for how to handle these patients. Bottom line is they should not get thrombolytics. They should not get tenecteplase or TPA, but they may be candidates for an intraarterial procedure. I would recommend, if you're going to be doing that, if you're going to be sending them to angio, that you get the MRI on the way. Make sure they actually have diffusion restriction. That's the only part you need, really. Because, if again, the mechanical thrombectomy, there's no data there yet. But it would be potentially appropriate if they had restricted diffusion and you didn't have a lot of hemorrhages. Okay, so code stroke challenge. Again, they come in as code stroke every time. I can't stop that train. Even when we call the ER and we say we're sending them from radiology, they put them in as code stroke. I think there's just too much pressure for stroke centers to combat it. So please be aware and make sure that your colleagues are aware. Especially any patients that have like confusion or dementia, be thinking about this. They may be coming to you, they may be getting their treatment somewhere else and showing up in your ER. And this is where radiologists, I think, are critical. All right, so what I wanted to tell you next was just a little bit about what we've been doing at WashU. There's a lot of words on here. You don't have to read all of it, but our clinic, over the first 14 months that we started it, we actually screened about 4,000 patients. And out of that, we had 234 that actually went on to therapy. Mostly they're in their mid-70s, but not everybody. And we had 9% of them that are E4 homozygotes. And our ARIA rate is pretty high. It's 22%. So that's a little bit higher than what was posted in most of the clinical trials. And I will say that overall, it's been very safe and effective. And a lot of that is because of these collaborative conversations that we've had between not just radiology and neurology, but between the university and the whole hospital network. I'm going to switch it to this just so you can see this. So this is showing you, this is kind of like these cancer survival curves. This is our population in our clinic showing their rate to ARIA. And you can see that if you look at any ARIA, most of the time it is occurring in those first 12 months. we only had 14 months of the clinic here though to look at. This is the other thing, is if you look at the radiographic severity, these are the asymptomatic patients, they're predominantly having very mild findings for ARIA-E and H. There's only one person that had a severe ARIA-H, moderate ARIA-E that was asymptomatic. And then this is the same data if you look at it in terms of symptoms. So you can see the good news is usually if they're having moderate or severe radiographic ARIA, they are having symptoms with that. And when you're having mild radiographic ARIA, they're usually asymptomatic. Why am I saying that that's good? It's because if you happen to miss it, the mild case, the clinical consequences aren't that bad, really. Okay. So just to recap, so this is where I was going to end the talk, was just going over the same findings that we went over earlier about communication, the imaging, et cetera, except as I got off the airplane, literally, I had a text message. I couldn't tell who it was from. It, the name wasn't in my contacts, but it was, Tammy, I just sent you a case. I think it can wait till tomorrow. It's an ARIA case, but it looks like press. Is it ARIA or press? And I'm like, I couldn't see the images at that point. I just had the text message. And so hopefully you guys know, I didn't even have to look at the case to text him back and say, if you're doing ARIA monitoring and it looks like press, it's ARIA. You need to call it ARIA. So I said, oh, okay, thanks. And so, so finally, I get to my hotel room and I sit down and I open it up. I'm like, oh, I think I'll add this to the presentation. That looks pretty good. And I look at it and then I realized, oh, well, there's also some findings on SWI. Now this is blurry, she's moving, et cetera. But if you look, 2 of those sulcal effusions are dark on the SWI. So she also has siderosis. So then I start digging into the chart to see what's going on. And I see that the infusion was scheduled for the same day. I don't see any documentation of radiology phone calls to the clinic, but I do see that one of the nurses saw the result and called the infusion center and stopped the infusion. I also see that initially they thought it was asymptomatic, but on further questioning, she's having intermittent blurry vision. So it is mildly symptomatic. And I see from the plans in the chart, they're going to hold the infusions and get another scan in 1 month, which is great. I wish our report had said that, because it should have said all of these things. It should have said that we called them and that we recommend getting a 1-month MRI. We also didn't say the siderosis. Okay, so management, this is where I wanted to get into this, symptoms plus imaging. So we've got moderate MRI findings and mild symptoms. So their decision was to pause the dosing and get the 1-month follow-up. Does it make any difference that we missed the siderosis? So in this case, no, in the sense that they're still in the same category. So a moderate ARIA-H would still be pause the dosing, get a follow-up in 1 month. Now, this story actually has a third part. After I put these slides together and uploaded it, I'm checking my email this morning, and I have an email from the neurologist who says, Tammy, I wonder if you could take a look at this case. Now, he doesn't know I've had anything to do with this case. And he says, I was just looking at it, and it was called moderate ARIA-E, but nothing else. But I see some arrows on the SWI. Do you think this is siderosis? Because the arrows that I put on to make this figure showed up in Epic, and he saw those. And I said, yeah, I reached out to Dr. So-and-so, the radiologist, and he's going to be addending the report on Monday. So with that, hopefully I've convinced you guys that there are a number of pitfalls, but they can be successfully navigated. And I thank you for all of your attention.